आज के इस एपिसोड में हम लोग नॉन मसल इन्वेसिव ब्लैडर कैंसर के बारे में बात करेंगे। इसके लिए हम एक केस स्टडी लेते हैं। 70-year male presented 2 years back with a painless hematuria and TURBT and TURP was done. Then patient completely lost the follow-up without taking the intravesical or local therapy in the any form, either intravesical BCG or intravesical chemotherapy. They had not taken and they lost completely follow-up. Now patients presented with the 1-2 weeks of the history of painful hematuria, severe pain while voiding and dribbling of the urine, that is having the severe irritative, obstructive, LUTS along with the hematuria. That was the presentation. Now the presentation has changed completely. The scenario is different. Now we have evaluated the patients either in the line of bladder neck stenosis, that because the patient had the TURP as well as the TURBT, so in the line of bladder neck stenosis as well as the stricture urethra, so we have advised the RG was done, that shows the meatal stenosis along with the stricture anterior urethra, that was dealt by the meatotomy as well as the EIU. At the same time, when we inspect the bladder, then in that there is a tumor which is solitary, present at the anterior wall of the bladder, almost at the same location that was initially in 2024. So that was definitely the urethra was dilated up to the 24 French resectoscope was used, and the tumor was resected, taking care that avoid the bladder perforation, because the tumor is present at the same location that was present initially in 2 years back. One thing. Second thing, that bladder is inspected thoroughly to see the multifocal disease or recurrence at the other places, like both the lateral walls, posterior walls, as well as the trigones. That was thoroughly inspected, but there is no any gross tumor present at any location except at the anterior wall, that is 3 centimeter into 3 centimeter tumor that is located at the anterior wall of the bladder. This is abnormal one. So the tumor is resected by a standard technique, TURBT, using the monopolar current at the low wattage, that is at the low energy. So the TURBT was done, and all the superficial tumor along with the muscle layer was resected out and sent for the histopathological assessment and histopathological examinations. And now the plan is further to do the intravesical therapy. Since the tumor is recurrent, so we have to keep many things in the mind, because where the tumor is deep-seated, so in this case I advise further after 6 weeks the CT scan to see whether this tumor is the deep-seated or having the muscle invasive component. First thing. Second thing, have patient has not taken any intravesical therapy, so I like to put this patient on the intravesical therapy in the form of intravesical chemotherapy as well as intravesical BCG as per the protocol of the induction therapy, and in the form of maintenance therapy. So later we'll see that this patient requires the close follow-up to deal with and to treat these patients. Now after that intravesical therapy, that's we have to see the response of the intravesical therapy. So my plan in this case is give the 6 dose of the intravesical BCG, 80 milligram in 80 ml of the normal saline as a standard dose, and we'll see after the 6 weeks by the scopy how the patient is. Thank you to patients' hearings. Thank you everyone. Please.